I have with me today Dr. Adriaan Louw. He is one of my heroes in the pain science world. Good to have you, Adriaan.
Yeah, thanks for having me.
So the thing that I really wanted to get into that I think, you really have taken to a whole nother level is your storytelling and the storytelling of different types of pain. Like, how do we communicate with patients? I think so often, if we are blessed to, have the science, and this is Adriaan's book, Pain Neuroscience Education. It's his residency and education program through Evidence in Motion now. And we start learning about the science, which is phenomenal in and of itself, to know what's centralized pain, what's peripheral pain. But I think that what you've done is you've made it accessible to patients. And that's what I'd like to talk a little bit about today, of what was part of that journey to be able to make these conversations with our patients that are dealing particularly with centralized pain. So the floor is ours to discuss for the next hour. I'm sure that we'll fill it up between the two of us.
Yeah.
But what sort of took you down that road?
Well, it's easy. I want people to know that I've been blessed by being around some of the smartest people in the world. So no, I didn't sit one day and figure it out. I will be straight up with you there. I was lucky enough to meet David Butler earlier in my life, and he was my mentor. He trained me, and then later on Lorimer Moseley. So I've been around this pain world for about 20, 25 years. And so the cool thing is I learned through that process, right? And this was heavily influenced by people like Louis Gifford was around that time. A lot of other people were involved in this. So I didn't come up with it. In 2003, the iconic Explain Pain came out, and I was working with David on these stories. No, I wasn't working the stories. David created these stories. And I would teach. I was kind of his road warrior, if you will, right? Every weekend, teach a class. And then through that process, you refine the stories, you learn a story, but then you create your own or versions of it. And then, Brent, very simply stated, in America, our clinic system's different, right? We have time is of the essence, in, out, fast pace. So I found myself on the weekends learning some cool pain stories, but I had to do it in 10 minutes Monday morning in a clinic because my next patient's already there. So I think that's where the part for me personally started, is taking these complex ideas, the really cool work done by these pioneers, but then shaving into little bite sizes. And then that led me towards my PhD work, which we created these stories, new stories, then basically that could fit into a clinical setting. And then we tested it, validated all kinds of research where people read through it, tested, patients got mad at us, they got happy with us. Until we shaved it and said, this works. And then the testing started in all our research with these stories. But that's probably the easy, dirty way of how we got here. And then 5 stories became 10, became 50 stories, different stories for different conditions.
I met David Butler and Lorimer Moseley in Australia probably 20, 30 years ago. And I think it was a global low back and pelvic pain organization from, oh my gosh, my memory's slipping me, but he's from Holland, I believe. You know what I'm talking about, that organized that conference that went every 3 years, the low back pain conference. Anyway, that's where I met David Butler the first time. And it was before he had Explain Pain come out. And then I met him again at the World Congress in Belgium, I think. And that's where the book had come out, and we had a chance to talk about it. And of course, I was fascinated because my doctoral work was looking at chronic low back pain in particular, but looking at how do the psychosocial aspects impact. So I was doing something a little more subconscious of saying, like, if I can create a positive movement experience with them, they can't live in that paradigm anymore of movement equals pain. And yet, there still was so much more with that, because so much chronic pain. If I got 20% of 100 people better that were dealing with chronic pain that were everybody else's failures, I was successful. Yeah. But then I was looking at a lot of your work of making these things available in the American healthcare system that could really make a difference. And that's, so that's where my hat's off to you, being able to make something work in the American healthcare system. And for that reason also, I've always been an advocate of cash pay and making things accessible to patients in a different way, a different system, where when I was growing up in the PT world in Sacramento, California was the capital of HMOs back in the early 90s. And basically what that meant is that you got paid $25 to $30 per visit, and you had 5 visits and you had to make a change. And I remember thinking, like, I'm not going to buy into that system, but in my 3 to 5 visits, I have to make a significant change. And that's why I started realizing that the behavioral science, the psychology of pain, of belief and hope and those kind of things, and understanding where pain was coming from became a central point of what I was looking at from a movement standpoint that incorporated the psychosocial and then so well enhanced with what you've done from the education standpoint, which is what we're really looking at here today, is like, how do we become better educated to educate? How do we better educate our patients, our clients? How do we help them understand their story in a way? So I was wondering if we could like take an example of one of your stories and just sort of share an experience you had with one of your patients, one of your many patients, that sort of how these stories could connect with them and how they could relate to it versus having some authoritative, information coming down with big words and diagnoses and scare the crap out of them.
Yeah, I mean, the goal is to take some of the more complex pain and put it at a level where a patient goes, I got it, and makes my life better, right? There's so many of these stories. The one that resonates a lot with me, this elderly lady walked in one day in the clinic. She was post-op. She had a humerus fracture. She walked down the sidewalk, slipped on the ice, humerus fracture, and then had surgery done. And she went 1 month post-op to the surgeon. And while he was examining her, he asked her, are you doing okay? She said, yeah, but, every day that I go outside, the cold air hits my arm. I get this nasty zing in my arm, like an electrical shock. What's that all about? And I know the surgeon pretty well, is a pretty cool guy. And he said, well, there's this therapist I want you to go see now. And she was kind of hesitant, but she came in. And I remember sitting with this lady. And, the part that people miss, Brent, is I obviously did a thorough evaluation. People think all we do is just tell stories. I had to make sure she was safe, check everything, make sure. We looked at her range. She can barely move her arm. She's got a home program. And I asked, what's the biggest thing that bothers you since you've had the surgery? And she said, exact same thing. When I go out in the morning, it's cold. I feel my arm. It's a zing in my arm, and it's really scaring me. And I said, has anybody explained that to you? Well, no. So I explained to her that very simply, there's in our arm, there are 3 main nerves. And yes, I gave her the anatomy. I told her there are 3 nerves. I showed her a picture. We call a median, radial, ulnar. And I asked her, can you say it? Median, radial, ulnar? It was so cool. Gave her an impromptu anatomy lecture. I said, well, where you broke your arm, the nerve that wraps around that area is the radial nerve. Say it, radial. So she's getting all excited. And I said, inside of this nerve, there are sensors. And we now know when life is good, our sensors are balanced. From your shoulder to your elbow, there are 20 sensors. Let's say 20 today. And when life is good, there's 5 red, 5 green, 5 blue. They're very balanced. 5, 5, 5 are all good, but they change all the time. And these sensors, if you get too many of one kind, you become sensitive to it. And in this case, what happens is there are sensors that can tell us how cold or hot it is today. There are sensors telling us, hey, you're getting stressed. Be careful. You're going to get a stroke, right? So I showed her a picture of some of these nerve sensor stories. We've developed these ion channels, if you will. And I remember her sitting there, 84 years old, smart as a tack, by the way, highly motivated to get better. And she said, so what you're telling me is my arm is actually okay. I said, yeah, the surgeon did a great job. That's why he drives a Mercedes and I don't. The arm is, you got your home program, but there are so many sensors right now that are sensitive to cold because when you slipped, it was cold out. So your sensors are just on full alert saying, protect, protect. So it doesn't surprise me when you go out in the morning, you get a zing. It's just telling you, hey, be careful. It's cold out. There could be some ice. And I know it sounds silly, but in the most basic terms, I remember her just sitting there going, she said, wow. She said, so do I need therapy? I said, well, for this one, not really. I mean, you can do some movements and range of motion. If it was a stress one, I could teach you some mindfulness, some relaxation techniques, some breathing. If it was, the movement one is sensitive, I can show you exercises. But no, not really. Tomorrow morning, when you go out, if you get a cold zing in your arm, instead of going, oh my goodness, just go, oh yeah, the guy with the funny accent explained it. And what really happens, your system dampens itself and you become less sensitive. And, the final part of this simple little story is a month later, I saw this lady at the grocery store. We always bump into our patients at the grocery store. And I walked up to her and I asked her, how you doing? She said, it's amazing. My arm's getting better. And she said, it's not cold today. And I said, well, only you would know. And we kind of laughed and chuckled or whatever. And it was so cool for me. What I want your listeners to understand, we took some of the most advanced neuroscience here. These are ion channel research, which Pfizer is spending $2 billion a year to create drugs. We put it in a story where a patient got it, she understood it, made sense, and actually changed her pain behavior, if you will. And so that's one. I mean, there's a whole bunch of these, but
well, I want to talk about that one. I mean, that's because I think this is last time we talked about things like catastrophization and sensationalization, and that we're often the culprits of that. Like we, as the practitioner, and we see this even in Pilates teachers, that they get a little bit of education about a pelvic torsion or scoliosis, and all of a sudden it's like this major diagnosis, and oh my God, you have scoliosis and you've got a pelvic torsion, and the patient's like, I have a pelvic torsion. And, it might have something that might not have anything to do with what's going on, but we've created the sensationalization. We heighten that sensationalization. So like I've had patients come to me and, they reach in their pocket to pull out keys or something, and the keys fall on the floor, and they get this horrible distressed look of like, oh my gosh, how am I going to get those keys off the floor? My therapist said that I can never bend forward, or I can never, round my back ever again, or tuck my pelvis under. And so people come packaged with a lot of stuff, right? And then also what they're experiencing, like this patient, I was just making some notes down. To me, the most important thing was her recognizing and verbalizing, so my arm is okay. Like for her to have that realization, there's not acute tissue damage happening. There's no nerve being ripped. There's no bone that's not healing. There's no muscle torn in half, and all the ideas we have. And I can tell you, as somebody who experiences pain, I mean, my imagination can go bonkers. Like it can go nuts. We'll talk about that a little bit of an episode I just had this week. But, the idea of being able to have somebody coach you through this, of why they would have hypersensitivity in that situation, right? And what a beautiful story to think that, it was cold and they were already signaling. Yeah. They were already telling the brain that it's cold outside, and that nerve got, irritated, and that's where the fracture was, and now it's healed up. And now that, it's messaging. But once they understand that, and I think we could talk about 100 cases, that once they understand the mechanism of what they're feeling, especially with centralized pain, like you talk about the lion within, and that's also David Butler talking about that, explain pain. But the idea of being able to identify and go, oh my gosh, whenever I get financially stressed, my pain increases 20% or 30%, to be able to articulate that. All of a sudden it's like, oh, so it's not tissue damage. I'm actually okay, or I'm at this level, but these are triggers. And for them to to have some kind of story like the one of, look, these messages were coming in already to the brain of the temperature, and you fell and you broke your arm and it's healed, but now it's just sensitive because was related to the original injury.
Brent, I just want to quickly, the one thing I think that I need your listeners to understand, you have no business explaining to somebody a story like this unless you've done your due diligence. I had to make sure she was safe. Yeah. I had to check the range of motion, check the arm, because I think a lot of people think all we do is we just sit and tell stories. No, I will tell you 90% of our patients actually after the physical exam become actually quite emotional. And when I ask them what's going on, I say, that's the most thorough medical exam I've had in 10 years, because we tend to kind of brush over people with chronic pain like, yeah, they hurt everywhere. So you got to check them so they feel safe. And then in this safety, you say, hey, has anybody explained this to you? Because a lot of people on social media out there are saying, well, all Adriaan and his team does, they tell people stories. That is couldn't be further from what we're saying here. We as providers have to make sure people are safe to do what we want them to do. And then we can tell them the story about their pain.
And I appreciate you bringing that up. I mean, this particular group we're talking to today are looking, I mean, they're movers, they're teaching movement, they're assessing movement. They're looking for any kind of, dysfunction, weakness, impairments, things that would get in the way, and then trying to understand, is this impairment related to weakness? Is it related to lack of awareness? Is it related to a belief? Is it related to a lack of mobility or tissue damage? And then to be able to make the decision. So I appreciate you saying that. There was something else that you brought up that is a huge topic, has been for years and continues to be even a bigger, is, the pharmaceutical companies. So, I participate in a number of pain groups, and the state of Florida has a pain group, and it's mainly anesthesiologists that get tired of working in the hospital, and they can prescribe higher amounts of opiates than the normal doctor. And of course, there was a big, crackdown on that just a couple of years ago, where half of them went to jail. But the idea of our belief of taking care of pain in traditional healthcare is primarily pharmaceutical, and it's still driven that way. And we just have this belief from the top down of the doctor saying, you got pain, here is some tramadol, or here is a little stronger, here's a little bit of oxycodone, and even stronger, here's some oxycontin. So tell me a little bit about sort of how you navigate some of the pharmaceutical aspects with, and what you've seen, probably more than that, of just some history of what you've seen with patients and clients that have been able to avoid going down the opiate pathway, because you were able to make sense out of what they were feeling to a level that you've taken that, like her pain level and her symptom level came down with the understanding of it, again, cleared from any pathological kind of obstruction. But that's, to me, is very important. And, how do we do a better job? And I think when we look at people that are movers and that are body conscious, having some of these understandings can tolerate a lot more pain or discomfort if they understand that they're okay. But there's a lot that don't. And so the most obvious thing is, give me drugs, give me pharmaceutical.
Yeah, I mean, the idea of drugs is it's so much in our fabric in our society. And for us as movement people, we need to make people more aware that there are so many non-pharmacological ways of calming the system down. We have published some research where we've been able to taper patients completely off opioids with the use of P&E plus movement. We've done preoperative studies where we've taught people about the pain before surgery, and then following knee replacement, 30% fewer opioids, and et cetera. So with those research we're doing, I think it's a travesty that we don't do better as a society to explain to people how movement, mindfulness, sleep, nutrition, all these things have as good effect sizes in many ways to ease pain. And talking about chronic pain, I mean, yeah, you have a femur fracture today, you fall down, whatever, let's take that drug for a short time. But all the current evidence strongly suggests that those strong opioids only really active should really be used for a week or less. Anything more than that doesn't make a lot of sense. The two biggest entry points for us in opioids right now is the emergency rooms and actually dentists of all places. And so we need to be careful. The strategies that we as movement-based people do, I don't think we even understand how powerful they are. For example, a 6-mile run right now, I mean, how many of our patients can go run 6 miles, but you start somewhere? A 6-mile run produces 10 milligrams of morphine in the brain. And I want people to wrap their mind around it. If you broke your arm today, and I went to the emergency room, they're going to give you 2 or 3 milligrams of morphine to set your arm and put it in a cast. That guy that just jogged right past the emergency room is getting significantly more. Now, what do we do with a person in pain? You don't start with 6 miles, but you start with 2 minutes of walking, that becomes 3, becomes 4 with overgraded exposure over time. The research is overwhelming, absolutely overwhelming. But, society—
And the endogenous versus the exogenous is a big difference too. So
absolutely.
I think
it's safe. It's way safer. But, we're in a culture where I want it today. And while you're at it, why don't you supersize it? And the scary thing for me, actually, Brent, is the next generation. I mean, FDA cleared hydrocodone for kids 8 and above now. We're teaching young generation the Pavlovian model of if you hurt, you take a drug, so they become used to it. And so I'm actually more interested in the idea of, can we train kids not to do it, because they're next generation adults. We just did a study in middle schools, 9 states, where we train middle school kids about pain. And during the school year, they use 30% less pain meds by just learning a little bit more about how pain actually works. You're sore but safe. Just because you're hurt doesn't mean there's something wrong with you. And so there's just changing beliefs in people. And, we need to take this to another level in terms of society. But as I always say, and I'll finish here, do you think Pfizer will sponsor this for us, or the American College of Surgeons or whatever? No, there's money to be made, right? And it's such a yucky system. But yeah.
Yeah,
Louw,
you're preaching to
talk
the
about
choir here. We tested a movement farm last summer for children. So it's here at the farm up in North Carolina. And, I always had a philosophy with our own children growing up that, you got to stay outside 3 hours after school. And the only way you come in is if a bone's sticking through your flesh, like you're going to stay out here, do you just play? So it was like that kind of idea of learning how to get up when you fall out of a tree, or when you accidentally get kicked playing soccer, or you bumped your head in the swimming pool or something like that, but learning how to deal with some of those, pain mechanisms that exist. And so that was one of the things with the movement farm, not so brutal, of course, but it was like, climbing a tree is hard.
Yeah.
And it's a little scary, and climbing a rope and, doing some of these things, or running around the lake, that could be exhausting, and watching them sort of struggle, even 5-year-olds to 9-year-olds that we were targeting then, was amazing to see that within 1 week, the change in their perception, the change in their strength, their mobility, their endurance was drastic. And I think that one thing we've done is we've taken that out of the school system. And we've also had such a deal with, a fear of security and safety, that we keep our kids at home. And then the third one is gaming. So there was, there's a little bit on a tangent, but it ties into what you were talking about with your junior high school study, which I saw and appreciate very much. But they showed dosing of sedentarism versus dosing of activity in under 12-year-olds at greatly reduced cognitive development. And it was correlated with the amount of each of those. So if you had a lot of sedentarism, you would have a cognitive development loss. And if you had a lot of activity, you would have an increased cognitive development. So it actually, it doesn't always work that way. Sometimes you would see one correlates more than the other, and the answer to it is to be more active. But there was a direct correlation, reverse correlation in both of those. In the teenagers, all the way up to 25 years old, it was emotional development. And so when you think of the last 6 shooters, 5 of them have been under the age of 24, and they were all sedentary. They were all gamers. They were all on antidepressants. They were all having the side effects of those antidepressants, of slight side effect of, suicidal ideation and homicidal ideation. And, and then adults over 25, it's metabolic, direct relationship to these dosing. So I do think that, one of the things, and it'd be interesting to tie the pain into it, the pain education, as you're doing, in having these individuals realize how powerful movement is, and understanding what pain is as it relates to movement, because sometimes they're going to be sore. Sometimes they're going to have aches and pains. Sometimes they are going to sprain their ankle. But what is that, how does that play into the big picture of thinking like, oh my gosh, and they're having so much pain, they got to go get a drug, right? So I appreciate that. Let's tell another story.
Another story.
Yeah. Why we
have
got you here.
Do you have a case? Or do you
I got to
want-
get at least 2 or 3 stories out of you. Examples of cases that, vary in how you were able to help them discover their story, is really what it is.
Let's start here at least. The most valuable story, the one that's the highest ranked by all our patients, all our studies, all the clinical trials people are doing, is what we call the sensitive alarm story. I may have talked about this one before, but this one resonates with basically everybody in pain. If you hurt your back this afternoon, this is your story. Sprain your ankle, if you had surgery yesterday. And this is just the idea of our body has a living, breathing alarm system. So patient walks in, just had surgery. Let's say you had a laminectomy 3 days ago. He walks in your clinic, how you doing? Well, I still hurt really bad. What's going on? And then explain to this person, say, the surgeon did his operation. Then our body has an alarm system. Our nervous system works like an alarm system. We show them a picture of the nervous system. We don't shy away from anatomy. We show them a nervous system. But then the analogy comes in. Our nervous system works like an alarm system. When life is good, just buzzing along, enjoying a beautiful day, there's always a little bit of electricity in our nervous system. It just shows us you're alive. So if I were to punch you in the arm, the alarm system will ramp up, fire a message to the spinal cord, go up to your brain and say, ding, 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 Adrian's a jerk, call the lawyer, right? You just hit me in the arm. This alarm system is designed to ramp up and protect us. You sprain your ankle, ding, 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 go get some help. Well, you had surgery, so the alarm system is at full alert right now, protecting you. So now if you walk a little bit or you do a little bit of activity, the alarm system, the threshold is so low that a little bit of walking, ding, 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 the alarm says, hey, be careful. The alarm system warns us to not run the Chicago Marathon day 2 post-laminectomy. It says, hey, maybe this year we'll skip it. And so this is a story about sensitization, that allodynia, hyperalgesia, simple sensitization, but our nervous system ramps up. And it's interesting for me still how many people this resonates with, the idea that they know they're sensitive, that what I could do before versus what I could do now is different. So when we tell them you have an alarm system, when life is good, buzz is down here. When you have pain, the system ramps up and it's at a much higher level. So it's a threshold story, Brent. So before your surgery, before your injury, you could do a lot of things. You could run 5 miles, drive 5 hours in the car to grandma's house, stand for 3 hours in the kitchen, cook a meal. But since you've had pain, 2 minutes of standing, ding, 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 the alarm goes off, right? 20 minutes in the car, it's that contrast. And that's often when they get the aha moment. Now, in all the years, they've asked me 3 questions, how do you know this? Because they saw the neurologist Friday who drives a Lamborghini. And they'll ask me, why did it never calm down? And then what do I do about it? So how do I know it? And then we tie it to our evaluation. I can barely touch your back. I can barely move you a little bit. They know they're sensitive. Oh, okay, cool. Why didn't it calm down? Then we talk about biopsychosocial stuff. Well, Sally, we have some great research that shows us there are things around an injury, around an accident keeps the alarm elevated. So let me ask you this. If you go from doctor to therapist and your pain's not getting better, do you think your alarm will calm down? I've never had people say yes. They say, no, it'll stay up. They're smarter than we think. Yeah. Hey, if you're worried about money and your job and can I do my job, do you think your alarm will calm down? No. So they know this. And then how do we calm it down? Then we bring in all the cool stuff. Well, there's movement, there's sleep, there's nutrition, there's exercise, there's manual therapy, there's whatever. And then you give them a list of treatments, non-pharmacological. And then you just say, hey, pick one. Oh, what's mindfulness? Well, let's take you through a session and show you that. Oh, what's this? And then we create a system to dampen them down. But notice the focus is not on the disc or the facet or the SI joint or the tibia, whatever. It's your tissues are healing. Tissues heal beautifully, but your system has remained sensitive. And that one resonates with a lot of people, the sensitive alarm story.
Yeah. And I appreciate the idea. And I always think back of Lorimer Moseley's story of his walking through the woods with what do you call it, a boring talker. And, the idea of getting, bit by a snake, but he goes through that same thing of the alarm, but, he'd always walk through the backcountry. He'd always walk through the bush. And he said, it was the same thing. He comes up through the alarm system and the thalamus goes back to parietal lobe. And if you worry about anything, it's like, no, it's just you're walking through the bush. And then he collapses because he had been bitten by, a poisonous snake. And then years later, he's walking through the woods again and, has the same sensation. Something comes up against his leg, goes to his brain, and the brain is conditioned because he almost died from the first thing. But the result was he was in severe pain. When they lift up his pant leg, it was a scratch from a bush. So it was like to me, that's fascinating of how the brain can change the threshold based on our experiences, our perceptions, our beliefs, and being able to educate those things. And I think that's, one of the ones that I've really appreciated is being able to just draw a threshold, right? To show this is what a normal pain threshold looks like. And when we get irritated or we're scared or we're heightened or we have these experiences, the threshold can go down lower and the body is on alert to protect itself. And so right now, after evaluating you, and I appreciate you bringing that up, but after going through a thorough evaluation, the tissues are doing their job. They look good and the body's healing and, this is what's going on. So you don't have to worry about the tissues right now. They're going to do their job. You don't have any diseases that are going to stop your tissues from healing. I just taught a immunology and autoimmune dysfunction lecture yesterday at the university, but you don't have to, you have to worry about that. Your tissues are good. But then it's like for them to have that aha moment. And I think you and I both have these kind of conversations with patients, but it's the aha moment where they're like, oh, so my tissues aren't getting damaged? Because I think that's one of the most fundamental things that we have wrong. And I'm going to share my personal experience this week. I went through a very stressful thing in my family with my parents last week that I had to fly out to another state and take care of a bunch of really crazy stuff, sort of as, the end of life kind of things. And then I had to be back in Miami to teach on Monday. And somewhere between there, it was just for me, it's always relationships and finances that make a little thing become a big thing, right? So if we're looking at the lion within and really looking inside me, those were the two things that came to my mind. And it was just like what I had to let go of. I guess this is sort of like, maybe, and I'd love to have your comments on this, Adriaan, but for me, I had to think of, look, there's no major tissue damage. I might have irritated the nerve root. I do have a little stenosis. If I went and had an MRI today, you would see that. I was thinking, like, do I need a Medrol pack? Do I need an epidural? Something I got to be able to teach tomorrow. And I was feeling all this pressure. And then, my Elizabeth, who basically manages my schedule, she's like, stop. I'm canceling your patients. I'm canceling everything. Just stop. And it was like, when I finally allowed myself not to feel that pressure that I had to deliver these things, or that I had to deal with the money things for my parents, like within a day, what I would have normally thought would have taken a week on a Medrol pack, I was better. And so how much of it was tissue damage? How much of it was my lion? And very quickly we tamed the lion into the kitty. And, I got on the plane, I came home. Today I walked around, I'm doing better. I got on the bike for half an hour. I did my Pilates this morning. So maybe talk through that a little bit. That is an example of the alarm system you're talking about. Like my alarm my threshold was way low. I was fatigued and stressed.
Absolutely. And I mean, the analogy that I am glad you brought this one up, because, sometimes something that can trip our system is also emotions. We always think about injury, right? As movement people, we think about injury means pain, or, surgery means pain. In these kind of stories, when patients come in, I got all this pain, all this stuff. As I'm listening to you in a clinical scenario, I would probably just draw you a cup and say, you know what, Brent, we have an emotional reservoir. All of us had one of those days that everything goes wrong, right? You wake up, you oversleep in the morning, you run out of the house, grab a cup of coffee, spill on your shirt, the toast is burned, you're not even in a driveway, the kids are late to school, and then your day just goes south, right? But we've all had those days. You come home that night, you sit down and have a nice glass of wine, kind of soak in a nice hot tub, and you go, wow, what a day, right? We've had those. But when things add up, it's like a cup that we keep pouring water in. And once that cup reaches the top, it'll overflow. And that's when we shift to the alarm and tell a patient, you know what, Susie, we have a living, breathing alarm system. It monitors our body for ankle sprains, ding, 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 go get some help. It monitors itself for surgeries, for injuries, all those things, but also our emotional well-being. So when things add up, and the cup fills, it trips the alarm system, and it just starts ramping up and say, hey, you need to take care of yourself. So now we start feeling areas like we feel our back, our leg, whatever. In your case, obviously example, we would examine you to say, yeah, hey, Brett, your back's a little bit stiff. We need to work on some mobility, or whatever the case. So maybe the stenosis is a little piece, but it's not the whole picture. Because I would argue in this scenario, if we did surgery and got rid of the stenotic issue and not all the stress stuff, we didn't address the problem, right? Or piece of the problem. So it's the idea that emotions and all these things going on in our life can actually stir it. I love the idea that you can sit here a day later going like, well, duh, I know it, right? Life is busy, I was stressful. That's the insight that we got to teach the patients. Go, yeah, wow, I haven't had a lot of stuff happen around this time. But what you started doing, you canceled your schedule, your assistant did, you started working out, you did a few, what did you do? You started emptying your cup again. And when we empty the cup, it cannot overflow, so the system dampens back down. And that's usually, we use that as an example for headaches often. When people start getting headaches that trip for no reason, like, I don't need to have an injury, but I'm getting these headaches. Well, have you been drinking enough water? Are you sleeping enough? How's your exercise routine? All these, if you don't do these, you're filling your cup, it overflows. Yeah. And these are just little examples. They seem simple. And whenever people hear, they go, well, this is stupid. And I know that, but it works. It makes sense for people in the real world. Like, I got it. My cup is overflowing. Well, Sally, how do we empty your cup? Here's a list of things. How's your sleep going? How's your exercise going? How's your nutrition going? And it's ways of empty. They know the answers instinctively. They just haven't done it. And so that's part of the coaching process.
And that was totally the truth for me, because Monday I could not see the story. I could not tell the story. And yet I tell my patients all the time, all I'm thinking about is I've got so many things to do. I've got so many things that are weighing heavy on me. So many of my relationships, financial, time-wise, and commitments that I've made. And, I couldn't see through that fog. And I think a lot of our clients are in that same position. So it gives me a little more empathy for them when we get into those positions. But it was like, wow, I I really am struggling to see the light at the end of the tunnel. And then when we cut everything out and rested and got some sleep, because I hadn't slept for about 5 nights, it was all of a sudden like, oh, I can get out of bed today. I can move around. I went and taught my lecture. That was the only commitment I had that day. Came back, rested. And, 2 days later, after what I would consider, if I would have gone to the hospital, and even when I called my physician up and I said, hey, I'm in a little bit of a bind, the first response is, let's get the pain under control. And the question never came to me as to, somebody intelligent about it. What do you think is causing this, and what's going on in your life that is out of balance that would lead to something like this? And I think that, a lot of times that simple question, when you're looking at something, it's like, there's no way that a truly impaired epineurium in the facet, in the transverse foramina would resolve in 2 days. I think that's the other thing in my head, like thinking like, wait a minute, like when I had a really bad episode where I really did go into hyperextension, I have a stenosis and I had that, neuropathy down the leg for a couple of weeks. And that was what came to my head.
Yeah.
Was the experience, right, Adriaan? It was the experience I had before that triggered me. And all I could think of now, like the last 2 days, was thinking like, the body's pretty smart. Like it was giving me a warning sign, not only on the emotional state, but also, just in my low back where I hadn't had that pain for years.
But Brent, there's something really cool here that I think the audience have to watch. Pain, and because people talk about pain knowledge, right? If you know a lot about pain, you won't experience as much pain, those kind of things. And that is actually not true, because here's an example. You're highly intelligent, you know this content, you know all this stuff, but you get caught up in life and you experience real pain. A couple of years ago, Lorimer Moseley was on his blog about, he had some of the most excruciating shoulder pain, and the world was making fun of him because like, hey, Mr. Super duper smart guy, you should never have pain because you understand pain. Understanding pain is a piece of the puzzle. We're still human beings. And when this 86 billion neuron supercomputer up here thinks, hey, Brent is in danger right now. He's running on full empty. I need to protect. It'll turn on whatever it needs to do. And pain is the fastest way it can get your attention. And even in somebody as smart as you, with all your knowledge, all your experience, it turned on the thing that you understand probably better than anybody, back pain. And what a cool thing, right? So we need to be careful, because sometimes we think if we just teach people enough about pain, they won't have pain. Pain is normal. It's there to protect us. It's there to say, hey, Brent, hey, dummy, you need to sleep again. You need to slow down. You get, it's a beautiful system that is, and that's actually with patients. I've had a lot of success sitting with patients and say, hey, go home tonight. You had a great session in the clinic today. Go home, get something cold to drink, preferably a nice Chardonnay from South Africa, and then come back Friday and tell me what is good about pain. I mean, Brent, I've had people walk in like, oh my God, pain is not the enemy. It's a good thing. Yes, yeah. It's not a bad thing. That reappraisal, that pain is there to protect us. If you couldn't feel pain, you'd be dead.
They are dead, right? Isn't that the
yeah.
people that have that weird anomaly die before their end of their teenage years?
Absolutely, yeah. Congenital insensitivity to pain, Mendelian disorder. Pain is there to protect. So even through that experience, they can understand, wow. So but I love hearing your story. I'm not making fun of you. We talked about this before, but it's so cool that you experience pain. It's cool. Well, not cool, but I mean, I experience pain. Lorimer does. Everybody does. It's a human experience. But what do we do about it? Luckily, you had people around you that cared about you and said, hey, stop, time out, take care of yourself. You then probably instinctively like, oh my gosh, yeah, I am doing dumb stuff. I know better. And we should teach people those strategies so that when they get there, they can take care of themselves. But
Exactly. I think the other big thing that I just took away from this is, and again, these are things that we sort of have talked about before in the literature and in the conferences, but it's a beautiful system. I think that, and even maybe, pre-framing, pain as the beautiful system that protects us. It is our protection. And, one of the things we talk about a lot of in the Pilates and movement world is awareness, right? So we talk about awareness through movement. We talk about how people who are more aware of their bodies are more aware of their mind. They're more aware of how they impact other people with their words and their actions. They become more aware and conscious human beings. And, you know, to think that, to me, it's a little embarrassing, but I understand the reality of it, is that to get caught in something that I understand, I teach, I study, you know, and to be a victim of it. Good news is only 2 days, but the idea is, you know, how many people are living in that for years.
Yeah.
And, you know, to me, it's, you know, we have so much good that we can do in the world just by, you know, a couple simple things in a formula. You know, it's like those of us that are therapists and doctors, we assess, like you said, we look to see what is available. Is there really a tissue damage? Is there a disease? Is there a pathology that we need to be aware of and treat based on these symptoms? And two, teaching them how beautiful our body is, how beautiful the system is, how, you know, all of these things are teaching us to be balanced, to be aware, to be conscious human beings. I love that. And the cup being overflowing emotionally, oh, that was a nail on the head. We're getting a lot of great conversations and things in the chat. And just to do a little shout out that, you know, I was a little hesitant knowing that I would have Adriaan today, and I was hurting on Monday so bad. And I was thinking like, oh my gosh, it's gonna be so embarrassing. I don't even know if I could sit for an hour. And, you know, and as I felt better, I thought, oh no, I'm not only gonna entertain Adriaan for an hour and have him entertain us for an hour, I'm gonna bring up my story, because I think it's important, like Lorimer was doing in the chat, is, you know, like, hey, we all have it. And, you know, wow, what a big mind-opening experience to think of. Like, my cup was too full. Like I had too much on my plate, and the body and the spirit and the energy was just telling me that's the system. Like, you got to slow down. So very cool. Couple other things here. I see everybody just excited about watching the replay and watching more and watching it over again. So anything else? You know, I was just thinking of, when you talked about South Africa wine, we just signed an agreement with a new licensee in South Africa. So now Polestar has an official licensee in your home country, Adriaan.
Yeah.
So a shout out to Heidi. Heidi is the new Heidi and Andrew. So anything else that you'd want to sort of share with the group as far as how they can get more information? And I mean, you're teaching all over the place. You have, I know it's primarily for physical therapists. Are there any things that are interdiscipline?
Yeah, the pain stuff we're doing is all interdisciplinary. I mean, pain is not owned by a profession, is not owned by one group. That's definitely something. I mean, we have people from all walks of life going through all kinds of training, and it's different levels. Some people want to take a little bite size, take a little online course. They're fine. People go to end stages where they do fellowships or whatever in between. Our job is just, how many healthcare providers can we help? How many caregivers can we help to help others, right? We have billions of people on the planet that are hurting, and we need to get some help. So yeah, we training, classes, courses, all those things which people can obviously easily find.
And they can just go to Evidence in Motion and see that, or do they go directly to
yeah, they can just go to Evidence in Motion, and on our homepage there's a whole section on pain science. They click on it, all our courses, all the stuff we offer is there. Yeah.
So Kim Taylor asking a question. I don't know if this is the right place to ask. Well, there's never a bad question, but what about menstrual pain? And can some of that end up being considered chronic? And is there a story for that? So that's a reoccurring one.
Yeah, so I mean, first of all, that's a really good question. This is probably one which if I would refer to one of my pain specialists that do women's health. You know, I've written books on pelvic health. It's not my area of expertise, but a human pain experience is a human pain experience. So when we talk about menstrual pain, you know, what is associated with it? For some people, it's going to be a very traumatic experience. It could be something tied to it with memory, experiences before. And so sometimes in these scenarios, we have to kind of peel out beliefs and thoughts. If this happens often and it's quite traumatic or it's painful, we'd probably want to get in behind it. So we would do a battery of, let's call it psychometric properties, start peeling these layers and then get people to refer to as need be. Again, if you think about just menstruation itself, it's a normal biological process. that if you can, again, normalize the experience, then it shouldn't be probably that traumatic. But in a subset of people, it isn't just let's call it a normal experience. And again, I feel really silly today as a male therapist talking about it.
We're gonna mansplain you on this one.
Yeah, we're going to mansplain you. How's that for an answer? But, anything that people sit in front of us, if you look at motivational interviewing, some of the principles about it is normalizing, right? Like if you can normalize the experience. But again, understanding for some people, this is more traumatic, it's more painful. Then I would ask, why in this person is it more of a negative experience compared to another person, and what's associated with it? And there's probably some other layers we'll have to go through and find out what that is. With that experience, there's pain, and if there's pain, there's sensitization. With sensitization, we can talk about the system being sensitized, calming the system down, etc. But before I go any further, this is truly one of those scenarios where I would refer out. Brent, this is not an area
I do as well. As well. And I have a wonderful colleague, Pam Downey, that is a big leader in the physical therapy, women's health, and pelvic health world. And, again, I think if we look at it as, a reoccurring symptomology, right, of anything, whether it's, headaches is another really good example of things that reoccur, or things that happen in some individuals at certain times of the month, or they happen during menstruation, or premenstrual kind of things. And I think that, so there is so much help out there. Not everybody is, dealing with pathology that it might seem like, because the pain seems so bad. And I've certainly been surrounded by, women in my life who have dealt with this. And again, I would refer out. But I think that, there are a lot of tools in place for women that are dealing with this, and I've seen them have a lot of success.
Yeah.
So let's see, there was Samadi Marino said, thank you for an amazing meeting. Can you talk about pain and fibromyalgia? So fibromyalgia obviously is always a hot topic. It's funny that it comes up in my autoimmune disease lectures, always is where they put it in the university and in rheumatology. Yeah. But what are your thoughts on fibromyalgia?
Yeah, I mean, fibromyalgia is a very common disorder. I'll be honest with you, as we look at all the current data, there's all kinds of arguments. The immunologists talk about it, the rheumatologist talks about it, the endocrinologist over here, everybody has a spiel. The current best evidence we have on the research in the field is that there's a strong immune response that occurs during a pain experience. When we live with pain every day, so whatever triggers this, our immune system actually starts ramping up. In the initial phases, it will actually settle down, but then ramp up. And when we have increased levels of cytokine circulating through the body, it ramps up the nervous system. And so we start getting widespread sensitization of the nervous system. These patients' clinical scenarios of problems of focus, concentration, fatigue, sleep deprivation, they cannot fall asleep, they cannot get enough refreshing sleep, multi-system sensitization. So in these patients, there's a lot we can do for them. They have a sensitized nervous system. We can think about ways of dampening the nervous system with education, blood flow, oxygen, the movement parts we do. We got to work through a sleep hygiene program to teach him sleep strategies to get into normal habits again. We can talk about nutrition. There's so many things, goal setting. I'm very happy, at least to say that for fibromyalgia, there's been quite a bit of research in pain neuroscience education being quite effective. Where patients walk in, we explain to them why they hurt, what's happening to them. We set goals and we progress them along the pathway. And so there's some seriously good research in that area, but it's an immune response where the nervous system ramps up its sensitization. The immune response alters blood-brain barriers, which alters cognitions, and it's a whole cascade of events. But people can live very successful lives despite having fibromyalgia. That's our goal, right? There are people today with fibromyalgia starting a business, getting their PhD, whatever. So I always tell my patients, can I fix it? I cannot fix it, but I can get you to a point where you can get on with your life, and to the point where you're like, I don't have time for this. I got to move on. I got to raise my kids. And that's that shift towards their goals and their function. Unfortunately, just people often are sitting over here and they have no idea how to get from A to B. And that's our job. And then they start saying, oh, B can take me to C, to D, to E, down the path. So sounds easy.
And it sounds easy, but it's tough. And I have a lot of patients with that diagnosis of that syndrome. And, one of the things, again, I think the pain neuroscience education is one of the best tools to at least be able to calm down. It's not necessarily getting rid of symptoms, but certainly to calm them down and to deal with some of the stress factors that are in their life that ramp it up even more. And then movement and, frequent movement and movement that's not incredibly stressful, but movement that's regular. And there was a study done by a Dr. Lee, I think out of Minnesota, and he ended up using the Pilates equipment. This is back in the late 90s. And he thought it was related to limitation and relaxin hormone was his approach to it. But the intervention was putting a Pilates machine in their house and having them do Pilates 3-4 times a day. And he showed that what it really came down to was that their frequent movement of the body, gentle movement, decreased their perception of pain by like 70%. And that they still had that 30% pain, but they were functional. They lived a normal life. They, fulfilled all their duties. And I appreciate you bringing sleep up so much. I think that, we can't emphasize sleep hygiene enough in recovery from a disease, an injury, a surgery, a mental illness. Somebody also brought up PTSD, and I know we don't have time to go into PTSD, and it's very real. We see it a lot, especially all the wars we've been in the last, 4 decades. But anything off the top of your head on PTSD before we
we just published a paper, 2 papers on PTSD and pain neuroscience education. People can look up Tim Benedict. He's one of my PhD students. We took veterans, taught them about pain neuroscience, calmed their nervous system down beautifully. They could understand P&E, even with mild traumatic brain injuries, PTSD, they could understand it, and they had a dampening effect. And the paper we're just getting ready to, it's coming out very soon, that we submitted, got accepted, is that the quality of life improved significantly in the 1 year post intervention compared to people that did not get pain neuroscience education. So with a heightened nervous system that's sensitized, we can dampen the system with P&E, plus then obviously movement and all the other cool stuff we do as movement people.
Yeah. Well, Adriaan, thank you so much. I don't know if anybody else has another question. I always like to bring up, our education as well. And so the more that we understand and the more we sort of have our awareness heightened as practitioners to these areas of belief and behavior and other factors that influence the sensitization of the nervous system can really play a huge role in, helping our clients return to successful function. It doesn't mean that we're going to get rid of it. I think also today, a couple of takeaways that I wrote down, Adriaan, was, getting the client, if they really are okay, to realize that they are okay, that they can let go of the fear that might be triggering the heightened sensitivity of the nervous system. The idea of pharma not being the end all, and that we're sort of looking to be able to use pharma in a very, brief moment of severe pain to modify that. And that even brings me, like when I had the hip surgery, there was a really good pharmaceutical plan that the surgeon had. And it even included a couple, how he used a little bit of steroid, a little bit of nothing too much, that I really didn't even have to take any kind of opiates after the first day of the surgery, and that it was managed with Tylenol. And so just the idea of long-lasting marcanes, my brain's not, of having a block so that during the surgery, those messages weren't getting up into the brain. So I do think that surgeons and doctors and all of us are becoming more educated of that process. The couple of things I wrote down here was the alarm system and how beautiful the alarm system is in our body. It helps us with awareness. You use the term a lot of times, Adriaan, like there is great research that supports this. And I think that it creates confidence in the patient and hope for the patient. The reality, though, is that we have to be readers of that research. We have to be reading it and consuming it and learning what is in the evidence in motion, what is the evidence based studies that are being done that help us out with that. And I think we can't rely only on, if Adriaan said so, or Brent said so, or Lorimer said so. We need to be in the literature, and we need to be good deciphers of the literature. What is good literature? What is not solid literature, to help us be able to interpret how we apply those things. And for me, the best thing was my emotional cup was overflowing, and I had to empty the cup out to get back into a normal thing. So I thank you for that, Adriaan. Is there any last thing you'd want to share with folks on the? on the
No,
call with us today? No?
everything you just said, the most powerful words ever recorded in medicine. You're going to be okay, and reassurance is analgesic.
Appreciate it. Adriaan, always a pleasure. We're glad to always promote the work that you do and John do with Evidence in Motion and the pain neuroscience education, and consider you our allies in movement. And I know you love movement. So thank you, everybody. Thank you for joining us. Above all things, be kind and have a wonderful week. Thank you, Adriaan.
Thank you.